Now, a 42-year-old woman comes to the antenatal clinic. This we have done. The next question, 33-year-old with solitary breast lump and a pregnant woman. What do you want to do? You can't give radiotherapy in a pregnant woman at any point of the gestation. Tamoxifen cannot be given. Chemotherapy is teratogenic only in the first trimester. But remaining trimesters, like 29 weeks of pregnant woman, it can very much be given, is what you have to basically remember. Please counter check. 38-year-old with type 2 diabetes attends the clinic. She is very obese. What are the things that you don't give routinely? Some of you are going to be finest obstetricians in the forthcoming in a near future. So, obese pregnancy is a complicated pregnancy associated with a higher mortality. They have a greater risk of pulmonary thromboembolism, gestational diabetes, etc., etc. So, you need to give postnatal thromboprophylaxis, regular screening for preeclampsia, and an active third stage labor should be done. What is meant by passive and active third stage labor? So, if you do induction, hasten the delivery, that will become an active management. So, that need to be done in order to avoid postpartum hemorrhage. They are all the routine things that are basically done. Now, a nulliparous woman, 27 weeks of gestation, 75 gram oral glucose tolerance test is performed. What is the benchmark sugar values? In a non-pregnant woman, 120 fasting sugar is a benchmark above which you call diabetes. But in pregnancy, you should strictly see that it is less than 100, in fact 95. 95 milligram per deciliter is the benchmark. If it is above 95, you need to worry. Similar thing, the post 2 hours post lunch, in a non-pregnant woman, above 180 you call diabetes. But in case of pregnant women, above 140 is unfortunate and unhappy thing for a obstetrician. That defines gestational diabetes, and you need to basically initiate, if required, on insulin. Generally with a good dietary changes. Dampudu biyam, you know, in Telugu, it's better. Non-rice food is much better, and walking half an hour after taking food. These are all the things that you need to advise your pregnant women. But above 140, in spite of these changes in diet and lifestyle, sugars continue to be 140 and above 2 hours after the lunch or breakfast or dinner. You need to put her on a sliding scale of insulin. You must put 4 unit, 4 unit, 4 unit, 2 hours, before eating. 2 hours after that, you need to ask them to strictly check the sugar. And if it is above 140, then you need to add 2 more units until you reach an adequate level of insulin dosaging 3 times a day. So that is the typical protocol. 29-year-old woman is seen at her booking visit and has blood taken for screening. What is the most appropriate set of booking tests? Every woman will have a routine syphilis, rubella, hepatitis B and HIV as a part of infective etiological diagnostic inquiry. Why not D option? What is there in the D? Let us see. HIV, CMV is not included. CMV is an opportunistic organism which will be there in anybody that we test. It's a starch group, but still CMV does not is not included in the protocol because CMV is routinely found. Anybody who is being done, they will be found to have CMV. Rubella only on exposure you will have. Hepatitis B and HIV on exposure only. Syphilis also on exposure. So that is the reason syphilis, rubella, HB and HIV. Good. If you do a good mistakes in mock tests, at least in the actual exam, so the point is you need to guess a lot of things. Everything is not what you read in the book. We do a lot of guessing while taking exam. But sometimes examiners will create questions that will go beyond the imagination of your guesswork. So that is the reason our mock tests are considered to be high quality, because we do all the effort in order to lure you into that seduction of picking up a wrong answer. 32-year-old has undergone MRI and typically her intraoperative findings and MRI has been shown. So here you can see a deeper penetration of the placenta into the myometrium and into the serosa. So intraoperative also it is reflecting, which is typically called as percreta, is what need to be remembered. 30-year-old, 29 weeks pregnant, unprovoked painless vaginal bleeding, which is about teaspoonful. Her anomaly scan has shown low-lying placenta at 20th week. But her cardiotocography is reassuring. What do you want to basically do? So any bleed, teaspoon or cup spoon or cup full or a bucket full, is considered an ominous sign. Especially if there is a documentation of a low-lying placenta that could turn out to be a placenta previa. That's the reason admit her intravenous access and you do grouping, and if she continues to bleed, then that is an indication for steroid. Otherwise, it is not an indication for steroid, is what need to be remembered. So small antepartum bleeds do not deserve a steroid injection unless they repeat, is a carry home message. Now, a 28-year-old pregnant, if you have any objection, please pronounce. We will be happy to listen and debate. Yeah. Why not? Yeah. Why not see her? Admit intravenous access, observe bleed, observe whether she is bleed free for 48 hours before discharge. That is your proposal, right? If the bleeding ceases and the woman otherwise remains well, there is no need of her to stay in the hospital for 48 hours. Staying in hospital unnecessarily increases the chance of infection. Got me? 48 hours is just to lure you. There is no such recommendation like keep her 48 hours or 72 hours unless your brother-in-law owns the hospital, right? And he wants to change his car. You can take that risk. Now, the membranes have ruptured. Is my voice clear? In this summer, for a couple of months, I will have this ocal trauma. I don't know, every year it happens. every time I feel, is there any laryngeal mass? So what happens is, in summer we put up AC, we live in AC, so obviously that is a effect of that. For a teacher, voice is life, right? For a doctor, for that matter. So a 28-year-old pregnant woman, she is 18 weeks pregnant and so far had no problems. She is worried because the fluid continues to come out and there is some blood. On examination, her membranes have ruptured. What is the best management? Do ultrasound, do infection markers and do observation. What are your other choices below which you have done wrong? We will debate. B. Offer her a termination as it is not possible for her pregnancy to continue. Membranes have ruptured. The membranes, she is worried because the fluid continues to come and there is now some blood. Earlier she had got large cone biopsy of the cervix and she is allergic to penicillin. On examination, it is apparent that her membranes have ruptured. If you confirm that there is a rupture of membranes, then definitely the prognosis is poor. Obstetrical outcome is going to be poor. That is there. But at this stage, without a definite evidence of rupture of membranes, it would be inappropriate to do the termination. So that is the only hitch in selecting option B. Kindly be seated, sir. I'll just take another 45 minutes to complete the class. We'll sit and talk. So she needs to be admitted. Why not steroids? Where are the steroids? Steroids are not here now. See, admit infection markers, ultrasound, and what is her gestational age? She is 18 weeks pregnant. She is 18 weeks pregnant. Are you going to deliver by giving steroids to her and mature the baby at the age of 18th week of pregnancy? Right? So, if the pregnancy doesn't stand a chance of continuance, the termination of the pregnancy is the only option. So, there is a reason steroids don't have a role, is what you have to basically remember. Yeah? Cone biopsy is a predisposing factor for a miscarriage. So, option number B. Offer her that's what I am saying. You are not it would be inappropriate to offer termination at this stage because it's only 18 weeks, and have until there is a definitive evidence of ruptured membranes or if the mother requested. So that's the only thing, right? Now, a 37-year-old is typically having 34 weeks of gestation, have a sharp pain in her chest, worse on inspiration. So wherever pulmonary embolism is there are two important outcomes of pulmonary embolism. Can you give me the board? Number one, if it involves the major pulmonary artery. So typically the lungs are there, you have the heart. So if it is involving the major pulmonary artery, what will happen, doctor? There is a development of pulmonary hypertension acutely that will put a brunt on the right ventricle, and that leads to the development of the right ventricular failure. How will you identify that the right ventricle is suffering from cor pulmonale and a RV failure whenever acute pulmonary embolism is there any way by which 2D echo you can do and discover it? Which 2D echo parameter will help you? Come on. If the right ventricle fails against a very high pulmonary tension, the right ventricle, one of the parameters will also rise. Which parameter? The right ventricle, while undergoing systole, it has to use more pressure in order to pump the blood against a very high pulmonary hypertension. You agree? So, what is that value called? RVSP, right ventricular systolic pressure. You can calculate it by doing the 2D echo. So, if the RVSP value increases on 2D echo, that means the right ventricle is pumping against a very high pressure inside the pulmonary artery, which develops when there is acute pulmonary hypertension because of the acute large thrombus which is involving the main pulmonary trunk. What is the second way in which pulmonary thromboembolism can present? The main pulmonary arteries become branch pulmonary arteries, and if it happened to occlude a branch pulmonary artery, then it lead to a segment of the lung to undergo infarction. Whenever it get infarcted, the overlying pleura become inflamed, and that lead to typically a pleuritic chest pain. How do you describe pleuritic chest pain, doctor? Whenever you take the breath, the pain increases, doctor, is whenever the patient says, sir, whenever I am taking breath, my pain is increasing, doctor, means there is a pleuritic element. That means a small vessel, small pulmonary vessel occlusion. Large pulmonary vessel occlusion presents like right ventricular failure. So what are the differences between right ventricular and left ventricular failure? Clinical presentation may right ventricular failure presents with elevated JVP. JVP is elevated. Pedal edema, presence of pedal edema, presence of ascites, and pleural effusion, etc., etc. Left ventricular failure presents with pulmonary edema. So whenever you are suspecting clinically, pregnancy itself is it a risk factor for pulmonary embolism? Yes. Pregnancy, because of the high estrogen, is a procoagulant state, which leads to development of pulmonary embolism. So any pregnant woman presenting with tachypnea along with a pleuritic chest pain, you should suspect the possibility of pulmonary embolism. So whenever pulmonary embolism in a non-pregnant woman is there, what is the investigation of choice, doctor? For a non-pregnant woman pulmonary embolism, CT angiography. If you do CT angio, then you can delineate the entire pulmonary vascular system and can identify that saddle thrombus, right? But in a pregnant woman doing a CT scan, what is her gestational age? 34 weeks of any gestational age, CT is radiation. You don't want to expose. So we should go for such an investigation which is not having radiation, but still can very much be used in the cases of pulmonary embolism. So what is such an investigation that you can do? One is D-dimer, assessment of D-dimer in plasma. Second investigation is V/Q, ventilation perfusion scan. So you inject a radionuclide, it acts like a perfusion. That film will act like a perfusion. You will take a chest X-ray and that acts like a ventilation scan. So in the chest X-ray, if the upper lobe is having any opacity, consolidation or a patch, then in the perfusion you will see whether the upper lobe is having a perfusion defect. If both the areas are matching, there is no mismatch. But if the lung is clear in X-ray ventilation, but the perfusion is showing a defect, then you call ventilation perfusion mismatch. So V/Q generally doesn't have a role in most of the clinical scenarios of pulmonary embolism, but it still has a role in the case of pregnant women who is suspected to have Pulmonary embolism is what you have to basically remember. Then doctor, 32-year-old, history of passing a gush of bloodstained fluid from vagina. There is a constant trickle since then. The admitting obstetrician typically does an antenatal ultrasound, shows placenta previa. What is the most appropriate management? She has a firm posterior cervix and has not been experiencing any contraction. That is, she is not in labor. She is a case of placenta previa with an antepartum hemorrhage. Whenever antepartum hemorrhage is there, what are the two possibilities? Abruptio or placenta previa. Then in this given case, since there are no contractions and she is at 36 weeks of gestation, which is a preterm, she can be called as a premature rupture of membranes. Generally, whenever there is any rupture of membranes, premature rupture of membranes, what is the protocol, doctor? Within next 24 hours, automatically induction is supposed to start. I mean, naturally labor will start. Only thing is, you need to give an antibiotic in order to take care of prevention of chorioamnionitis. If the labor naturally doesn't start, then you need to induce the labor, right? So that is the typical protocol. If at all premature rupture of membrane occur. When do you call premature rupture of membrane? Before the onset of labor, if there is any rupture of membrane, do you call premature? What is preterm premature rupture of membrane? If it is preterm. So you need to gain some time in order to give a steroid, 48 hours, so that the fetal lung matures, and then you can induce the labor and then excavate the baby, right? So that is the idea. So what do you want to do? What do you want to do in her case? In this case, why not option A and B are incorrect. What is option A? Induction of labor with the oxytocin drip. You are trying to do a vaginal delivery. Cervical ripening and prostaglandins followed by oxytocin drip. There also you are trying to do vaginal delivery. But her ultrasound is showing the presence of placenta previa, low-lying placenta near cervical os, where there is no role for the vaginal delivery. That is the reason it is indicated to do the cesarean delivery, is what you have to basically appreciate. I leave the literature for you as to why option D is not right, etc., etc. But you got the sense of why it is not cesarean. So physiological changes of pregnancy. What is the change in the plasma volume, cardiac output, total peripheral resistance, all these things. One question out of 30 questions will definitely come in the any damn entrance you take, doctor. If you have not prepared your 100 pages notebook with all these stupid muggable facts, 40% raised, 30% raised, it is like cotton market. Examiner will ask you 20% de do or 30% de do. So if you do wrong, in spite of all the wonderful preparation, still it become a bottleneck. You are all brilliant students. Remember, there is some useless stuff that you need to mug forcibly. There is no way. There is a lot of logical things you should understand logical way. The best students are the ones who do justice for both. You should not have aversion. If you have to remember rapid sand filter, sand particle size, or what is the thickness of the lead apron to prevent radiation, what is the depth of the septic latrine in SPM, You should not say, no, 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 who will do? Remember all that sanitary remembering. No. Entrance is ultimately Jo Jita, Wahi Sikandar. Right, doctor? At the same time, which type of renal tubular acidosis will there be nephrocalcinosis? Why nephrocalcinosis will only be there in case of the distal RTA? They're all logically, you need to logically understand them. What is a negative anion gap? What is positive anion gap? How to differentiate Liddle's from Gitelman syndrome? Logical. Acid-base disturbances, everything. That you have to logically master. So both the things you should do. Okay. So this is the best time, doctor, after you become MD. There is no fun. There is no thrill. Only one branch you will be seeing the same patients. Doing DM is killing lot of your otherwise acquired knowledge. Heart means only heart. A cardiologist will forget how to treat malaria. You know that? A cardiologist doesn't even know to decide whether his wife is suffering from gestational diabetes, how to define it. As you go up the ladder, there is very, very focused thing, only few things to remember. In cardiology also, if you become an arrhythmologist, you will forget when to thrombolize. Arrhythmia management guys only do electrophysiological studies and do pacemaker implantation. Only that thing they know from morning to evening. Right? So that's the reason, be happy. This is the wonderful time of life where you are reading everything. Enjoy the preparation. Very specific manner. My voice is killing me. Hope the online students are not missing the clarity, but to say there is a sore throat is a meaningless alibi to not come and deliver a class. So, plasma volume typically increases and RBC volume also will increase in pregnancy. But plasma volume will disproportionately increase than the RBC ones. That's the reason pregnancy is a state of relative hemodilution is what you have to basically understand. 30-year-old, she has her first child 2 years ago via emergency cesarean. She does not wish to try for a vaginal birth. She has tried the contraceptive pill in the past but does not like the side effects. And she is not sure whether she want or not want more children. So what is the given scenario? What do you want to do the best? Fundamentally, permanent sterilization is not an option because she is not sure. One fine day she may get a mood to produce. Yesterday, one patient, she is a 38-year-old top level bank executive. She had her first child, she was 24. She said, one child is enough, half is much better. At that time, with a lot of rigor and vigor, being a first, direct recruit officer in bank. She came and said, doctor, I'm so bored with the life. I want to try one more child. Her husband is a very, very, very successful, he is also a banker. So she got tubectomized at that point. Is there any way of recuralization, etc.? I have sent her to one of our very good friend who is a expertise in that. So doctor, no one knows when they want a second child. So sterilization is not right option. She is worried about hormones. So Mirena and everything has got progesterone in them. Not a right choice. So the best choice would be a copper T380. Almost about 7 years it will take care of the protection. Now, a 41-year-old multipara, she attends the antenatal clinic at 36 weeks of gestation complaining of abdominal pain and cramp. She has got a pansystolic murmur. A diastolic murmur any point of time is organic. It can never be innocent. A innocent murmur, typically what are the features of innocent murmur? Innocent murmur is systolic in timing. Innocent murmur will not be more than grade 3. Presence of thrill is grade 3. A innocent murmur, characteristic number 3, doesn't radiate. If it radiates, it is no more a innocent murmur. So why pregnancy, anemia, beriberi, thyrotoxicosis, patent ductus arteriosus, AB malformations? These are all the conditions where you listen systolic murmur, because these are all hyperdynamic circulatory states. And typically whenever there is a hyperdynamic circulation, even pregnancy, 40% plasma volume will increase. So what happens? Normally heart pumps, for example, 5 liters. It increases to 40%, nearly 7 liters will be a pregnant woman's blood, plasma volume. So when will you listen a murmur? Normal flow against a abnormal valve, or a abnormal flow against a normal valve, and in pregnancy 7-liter blood flows across a normal valve will lead to development of murmur, which is typically innocent murmur without any organic lesion. Typically it is systolic in time. So if you want to listen systolic murmurs, means whom do you listen to? Pregnant woman is one best option. Lachakka, Buchabba, who are our poor farmer's wife suffering from significant anemia, who get admitted under you. Anemic patients also will have systolic murmur. The moment you correct anemia, murmur also vanishes. Okay, doc? So, you need to reassure her. 38-week antenatal follow-up is the one that you are going to advise. 32-year-old HIV positive woman who booked for antenatal care, ultrasound shows breech singleton pregnancy, reactive fetal heart rate, and she has got painful regular contractions and cervix dilated to 4 centimeters, and she is at 37th week. Arrives on the delivery suite at 37th week. Okay. So what do you want to do? Painful bleeding is placenta previa. Painless is basically, in her given case, she presented with antepartum hemorrhage, right? Right. So, she being HIV positive, one of the most important precautions that you need to take is, you need to wash the baby. And cesarean delivery, wash the baby at delivery is considered to be the indication in her given case. Now, doctor, 41-year-old has got a large saddle embolus. What is the best, safest anticoagulant you can give to a pregnant woman? You have two options actually. You can give a low molecular weight heparin, which can be enoxaparin, common brand name is Clexane, and Fundaporinox. Both of them are indicated, but if you take the efficacy and safety, enoxaparin relatively is found to have a more efficacy. That's the reason enoxaparin is a preferred one. Generally, what is your call on anticoagulation pregnant women? For example, somebody has SLE, antiphospholipid antibody syndrome, procoagulant state, she became pregnant. What do you want to give? Do you know what is the cost of a enoxaparin injection? Come on, who will give me the practical answer? Oh, doctor? The sad state of our medical schools is so many exams, so short a time, and we were not taught, actually speaking, there will be not more than 50-60 medicines that we often use, doctor. Not more than 20-30 emergencies to manage: pneumothorax, pleural effusion, pulmonary embolism, right? Myocardial infarction, stroke, seizures. Then ideally what they should do is, when you enter internship, it hardly takes 1 week to make you experts in guidelines of all this. And entire 1 year should be a way to repeatedly practice those guidelines. But we read big pharmacology book without knowing what is the cost that of a commonly prescribed low molecular weight heparin. No worries, because we did not design. Britishers designed and left the country, leaving a British system of a stupid medical school, right? So there are two things, doctor: unfractionated heparin, low molecular weight heparin. If you give unfractionated heparin, you need to do APTT to monitor it. If you give low molecular weight heparin, no monitoring required. APTT can't be used for monitoring it. That is the advantage of this. Unfractionated heparin is 20 rupees or 30 rupees injection. But the APTT lab fellow will rob you, right? So he will charge you 150-200 rupees. Low molecular weight is between 300 to 400 rupees injection, but no need of doing APTT. Only thing is, you have to decide whether you want to pay diagnostic fellow or a medical shop fellow. If you have two brother-in-laws, one will run this, one will run this, right? Now, if you give heparin, one thing, pregnancy may you can't use a oral anticoagulant, because oral anticoagulant will lead to teratogenic effects. But can you give low molecular weight heparin throughout the pregnancy? What is the most common side effect of heparin? Come on. Huh? Loud. HIT, heparin induced thrombocytopenia, is a risk factor. So that is autoimmune phenomena, HIT type 2. So thrombocytopenia, but still you can give. But other than HIT, a long-term usage of heparin lead to two problems: osteoporosis and thrombocytopenia. So you cannot give. So the best protocol is, first trimester give every day heparin, and after that, until the time of labor, you give oral anticoagulant. At the time of labor, switch over to heparin. So that is the typical protocol. Very happy to see a very good number of online viewers, Chinta, Ray and many more. So alright, the next question. 21-year-old came with vaginal bleeding of 100 ml. She is 32 weeks and she has got an antepartum hemorrhage in the last pregnancy, and her ultrasound has been shown in the figure. So there is a posterior placenta, fetus, this is the fetus, and posterior placenta, ultrasound. And she admits that she and her partner had intercourse last night, and she is concerned by the terrible abdominal pain she is having. What is the most likely diagnosis in her case? So doctor, placenta previa is a painless bleed characteristically, whereas abruptio is a painful bleed. That's what you need to remember. Abruptio is a sudden separation of the placenta. But externally bleeding may not be significant. The bleeding that you see will be disproportionately smaller than the actual bleeding, and all that bleed accumulates like a retroplacental hematoma, and that predisposes to the development of shock, sepsis, DIC. All these are the problems in abruptio.